Thank you. As a behavioral psychologist or social psychologist, this is a bit of a different lens for me. I'm taking more of a bird's eye population view of these factors on this study. And I would first like to acknowledge the funding. This is funded through CFAR International Pilot Program with my international collaborator at the Institute of National Public Health in Mexico City, Mauricio Hernandez. And it also is a true collaboration not only with INSP in Mexico City, but also with Emory University, where the survey that we did implemented nationally in Mexico was a replication of the survey that's done in the US led by Patrick Sullivan's team. Emory. And this is just a disclaimer, data haven't been presented or published, but also that the study, while these analyses were done on the data collected at the time we closed active recruitment, the study survey was actually closed on November 1st. And because of interest in looking at the data that continued to come in after the advertisements were there, this is not our final sample, and so results are subject to modification. All right. So in many low and middle income countries, they have achieved some very important declines in HIV-related mortality with policies and programs targeting universal access to antiretroviral therapy. In Mexico, the impact of universal treatment, though, has remained suboptimal compared to some other lower middle income country regions, noting that while Mexico is a middle income country now, most of its epidemic occurred during the process that it was not a middle income country. Estimates of people living with HIV in Mexico average around 210,000 people. 44% of people living with HIV don't know their HIV positive status. 50% test positive with a concurrent AIDS-defining diagnosis, meaning that we're seeing when people do test, it's delayed testing. And 40% of people living with HIV who know their status and are eligible for ART are not on treatment. So despite having the context of universal treatment, there's still a lot of movement that needs to happen in order to maximize its benefits as a preventative strategy. As with many Latin American countries as well, Mexico's HIV epidemic is disproportionately concentrated among men who have sex with men, where HIV prevalence ranges from 12 to 20%, depending on the region of the country that you're looking at. And regardless of what region you're in, it's quite striking compared to the national prevalence among men and women, which is well below 1%. In the context of the UNAIDS 90-90-90 goals, and I don't think they've been said yet, so I'll just say them real quickly. The goal is to seek to reduce HIV incidence through testing, treatment, and viral suppression, meaning that a country is focused, or a region is focused on getting 90% of all people living with HIV diagnosed, 90% of those diagnosed on treatment, and 90% of those on treatment virally suppressed. Available estimates for MSM specifically in Mexico are currently limited. One national study found 67% of MSM had ever tested for HIV in their lifetime, and this data is really lacking more nuanced information about recent and repeat testing behaviors, which is what would be needed to do more targeted intervention. A secondary analysis that was conducted by myself and colleagues here at UCSD on MSM in Tijuana suggested that 84% of HIV positive MSM in Tijuana did not know their HIV positive status, and only 50% of MSM who knew their status were in care and on treatment. So with this limited background, achieving 90-90 in Mexico among MSM really is first going to require a better understanding of the current levels of engagement in both routine testing, which per national guidelines is, for MSM is testing at least once every 12 months, and an understanding of post-diagnosis engagement in the care continuum reflective of timely linkage to care, post-diagnosis, and linkage or an initiation to ART, post-linkage to care, as well as sustained ART adherence over one's lifetime. And that knowledge really formed the overall objective of the pilot grant, which was to assess the prevalence and identify barriers and facilitators associated with routine HIV testing and timely engagement in the HIV care continuum among MSM in Mexico. Participants who were enrolled into our online study were greater than 18 years old, male identified, and reported ever having sex with other men in their lifetime, and also reported being a resident of Mexico. Our study logo, as displayed here, was present for our online survey of MSM in Mexico and used to recruit them. And recruitment, we use strategies to specifically target adequate representation of MSM from each state or district across Mexico. In order to recruit them, that banner ad was placed on both Facebook and other social networking apps popular with MSM in Mexico, such as Grindr. And the banner ads ran from May through August of 2017, which is reflective of our current analysis, though the survey actually closed on November 1st, 2017. Eligible MSM completed an online survey of 25 minutes on HIV behavior, as an HIV behavioral surveillance that was operated through Survey Gizmo, and all study procedures were IRB approved. Participants did not receive any form of compensation for their participation. The measures relative to this analysis that we're going to look at is HIV testing items that asked, in your lifetime, have you ever tested for HIV? And in the past months, have you tested for HIV? Yes, no. As well as self-reported HIV status categorized as having tested positive, negative, or an unknown indeterminate status. In terms of HIV treatment, what we mean by timely engagement in HIV treatment behaviors is that that behavior occurred within 1 month of the preceding behavior, so that following your HIV diagnosis, within 1 month were you linked to care? Once you were linked, within 1 month, were you enrolled in the medical system in order to access universal treatment? And following your enrollment in universal treatment, within 1 month, did you initiate ART? We also asked individuals whether or not they were currently on ART and their adherence level, which was categorized as greater than or equal to 95% adherence or less. The analytic sample of respondents was 2,890 MSM, and this was reflective of respondents who responded to 70% or more of the online survey after deduplicating ISP addresses from Mexico. And any ISP addresses outside of Mexico were excluded. Descriptive statistics were used to characterize MSM's engagement in these testing and treatment behaviors. And again, just a disclaimer that these are preliminary analyses. In terms of respondents for our HIV testing questions, 30% of MSM in Mexico reported that they had never tested for HIV, though 45% said that they had tested for HIV in the past 12 months, meaning that 45% met the national guidelines. HIV status of respondents at their last test, 58% reported being HIV negative, 11% HIV positive, and a kind of surprisingly high rate of HIV unknown or indeterminate status being self-reported. When we looked at HIV treatment behaviors among those who reported being HIV positive, 61% linked to HIV care within 1 month post-diagnosis, and 42 were enrolled in the national HIV care system, ensuring universal access to ART. And just to give you a little bit more context, as my colleague Eileen Pipitan said, that there are the universal access for HIV treatment is typically delivered through these CAPACITES clinics, which exist in only certain regions around the country. And you have to first go to that clinic, have a confirmatory test done, and then return back from that confirmatory test in order to be enrolled into the system. So there's quite a few steps that need to happen within that month. 38% of those who enrolled in a treatment within a month initiated ART within 1 month, but in total, 87% of HIV positive respondents did say they were currently taking ART. But among those, so that's everybody, not just those who were initiated within 1 month. But among those who were currently on ART, 65% said that they were adherent to their treatment regimen. Reasons for not taking ART were predominantly described as waiting to be enrolled in the HIV care system, saying that I had a high CD4 or lower viral load and didn't really need to start ART at this time, and 19% did not want to see a health provider about their HIV. So in order to pull this together and just give us a snapshot of HIV testing and treatment behaviors among MSM in Mexico responding to an online survey, we see that 45% are adherent to the national guidelines of routine testing, 61% are linked to care, 42% enrolled in access to ART in a timely manner, and 38% initiated ART. While the majority of HIV-positive MSM did say that they are on ART, only 65% were adherent. So in conclusion, this is the first web-based national HIV behavioral surveillance effort for MSM in Mexico. And one of the aims of this project was to be able to put in the infrastructure to continue this surveillance over time. These data indicate efforts are needed to increase routine HIV testing and then to strengthen the care continuum that are really critical to achieving the 90-90-90 goals to address current HIV disparities. And informed by previous research, in particular this image is from Sergio Batista at INSP, and where it shows you the striking difference in prevalence by different regions in Mexico. Future analyses will consider responses to testing and treatment needs that are appropriate at the state and municipal levels. And with that, I would really like to thank the participants, especially the men who participated without any form of compensation, to be able to give voice to their experiences, and also to our wonderfully collaborative research team and to the funders who gave us an opportunity to start looking at what the behaviors and the needs around HIV prevention and treatment support are among MSM in Mexico.
Great, thank you so much. So I'll take the chair's prerogative to ask a question first while everyone else is thinking, and that is that I'm really interested in this idea of using an online survey for behavioral and HIV surveillance. And I'm wondering if you can speak to a little bit about your experience about the feasibility of this, as well as whether you think the population that you captured is generalizable to the broader MSM population in Mexico.
Mm-hmm. So this is my first time collecting data this way. As you've seen in the other studies I've collaborated in, I usually, doing everything we can to reach populations. So this response rate was even higher and more rapidly acquired through the AMOS study, the version of this survey that's done in the U.S. Part of the reason we think that is this may have been one of the first times that MSM had an opportunity to speak about their experiences with other men. And we didn't just ask about HIV testing and treatment. We really kind of framed it more around their sexual health and well-being. So we think that in part drove the higher response rate. But to speak to the access question, approximately 70% of MSM have routine access to the internet in their homes. So there is going to be a bias, by and large, among by income, but not as striking as we had initially thought. And actually, Ricardo Baruch that's one of the research questions that will inform his dissertation about this analysis and the feasibility of this approach.
Thank you.
Hello.
Hi.
It's a great study. Congratulations. Very interesting. So I'm from Mexico City, and I wanted to know about the distribution, the regional distribution of your sample, because there might be differences depending on the place of the country, especially people in Mexico City who are more open, or in Guadalajara or in Monterrey, compared to poorer places like the south, in Oaxaca, Guerrero. So what's the distribution of your sample first?
So I don't have the final exact numbers for you. I can tell you that we definitely did have a higher, more rapid response rate from places like Guadalajara and Mexico City, but we also turned off the survey in certain areas and did more targeted outreach to other regions, because through Facebook, apparently you're able to say only allow ISP addresses coming from this region. So we were able to really do some more targeted recruitment in areas where it may be harder to be out. So people may have, migrated to the larger city, or regions that are poorer, where there may have been, less access to or not to ART, so used to saying that, less access to the internet. So we definitely have a higher representation from the areas that you're speaking, but we do have an adequate sample, I think, of at least 100 from all states across the region. Yeah.
Thank you. And can I have a second question? It's, about the linkage to care, how do you measure that? Is that also through the questionnaire, or you look for them in the Salvar database?
Yeah,
or?
so this is all self-report. It's not through Salvar. So you'll see different rates when you look at estimates that are reported, for example, from Cincita, or like a lot of Dr. Mahis's work, the estimates are much better,
yes.
but much better. But it's an issue of who's in your denominator there, because when you're looking at who has been entered into Salvar, you're obviously missing some people. This is also self-report, and so what we did is we asked years, to your best knowledge, what month and year were you diagnosed? What month and year did you first see a doctor? What month and year did you? So we broke it down in all the steps that they would need to go through that system, to go through, especially the Seguro Popular system, in order to get onto treatment. And that's how we calculated, within a month.
That's great, because there are these two systems in Mexico, the Seguro Popular and the Social Security. That care for people with HIV. There might be demographic differences in the two groups, and so it's important.
And that's something that
will the Social Security people that are less described than the Salvar, because it really is a mess. That system is really bad.
It really is, and we did ask what health system that they went through, whether it was Seguro Popular or whether they, were formally employed or not formally employed, and those are differences that we'll be able to look at and see. Yeah.
Thank you very much.
Yeah, thank you.
Any final pressing question?
I know lunch is
If
right
not,
behind
okay.
me.
Thank you again, Laramie, for an excellent talk.
Yeah, thank you.